Welcome to my channel, Fundamentals of Imaging. Let's talk about the step-by-step systemic approach to chest X-ray, part 1. Here we discuss about the positioning for chest X-rays. Commonly used chest X-ray views are the posterior-anterior view, anteroposterior view, lateral, decubitus, and apical view. Standard view is the posterior-anterior view, whereas the lateral, decubitus, and apical view are done only when required for the diagnosis of pathology. So, in posterior anterior view, X-ray beam is placed posterior to the patient. Beam passes from posterior to anterior to reach the image receptor. Whereas in AP view, um, X-ray tube is placed anterior and beam passes from anterior to posterior to reach the image receptor to form image. Now, um, deep inspiration is required for um, adequate visualization of chest lung field. Centering is done at the level of 7th thoracic vertebra and grid is used to reduce the scattered radiation and blurring of image. Detector size used for the chest X-ray is 35 into 43 centimeter and exposure given is 100 to 110 kbp 4 to 8 milliamperes for adequate X-ray imaging. Why adequate inspiration is required? So the structures that can appear different on expiration are heart size, mediastinal contour and width, lung inflation, diaphragmatic contour. So these structures size and outline varies according to inspiration and expiration. Collimation used for the chest X-ray is superiorly 5 cm above the shoulder joint to allow proper visualization of the upper airway, inferiorly inferior border of 12th rib, and laterally bilateral acromioclavicular joints. Now talk about the posterior anterior view. In posterior anterior view, patient position should be erect, facing upright to image receptor. And the superior aspect of the image receptor is 5 cm above the shoulder joints. Shoulder joints are rotated anteriorly by placing a hand in back pocket or on the waist, and the shoulders are depressed to move the clavicle below the long apices so as to not obscure pathology in long apices. Mm, Now, what is poor inspiration or good inspiration? How we know that this X-ray film is not adequate inspiratory film or not adequately uh, exposed. So, midpoint of the right hemidiaphragm should be between the fifth and seventh ribs anteriorly and around 10th rib posteriorly. If this criteria met, then the X-ray film is called good inspiratory film or adequate inspiratory film, whereas if it is less than that, then it is called poor inspiratory film, and if more than that, then it's called hyperinflated lungs. So hyperinflated lungs seen in the obstructive lung pathology, whereas the poor inspiration can lead to the obscuration of pathology, magnification of heart. Now, posterior anterior view, which is performed by placing X-ray tube anteriorly, and the patient position is supine position because it is done in critically ill patient uh, by portable X-rays, and the chin is raised as to be out of the image field, and shoulders are depressed to move the clavicles below the lung fields. So what are the differences between the PA and AP view? In PA, posture is erect, whereas in AP, supine. Scapula are away from long fields, whereas overlie long field in AP view. Clavicles are projected over long zones, and in AP view projects above the long apices, whereas the ribs are posterior ribs are distinct in PA view, whereas anterior ribs are prominent in AP view. Patient's hands are placed on hip or waist, whereas on the Sides of thorax in AP view. Heart magnification is minimal or negligible in PA view with cardiothoracic ratio is 1 is to 2, whereas in um, AP view it is significant heart magnification with increased cardiothoracic ratio, and diaphragm outline is lowest level in PA view whereas highest level in AP view, and gastric air fluid level is seen in PA view because patient is in erect position, whereas it is not visualized in AP view, but if it is visualized it is only gas, no air fluid level. Now we can see that the different images of PA and AP view. In PA view, clavicle is obliquely oriented with lateral end above and then medial end. Posterior ribs are prominent in PA view, whereas the anterior ribs are prominent in AP view. Scapula is within the long field in AP view, whereas it is not visualized in PA view. Heart size appears relatively normal, whereas in AP view, heart size is increased with increased cardiothoracic ratio, and diaphragm is slightly higher than in PA view. So these points differentiate PA from AP view, and in PA view, long field is better visualized than the AP view. Now lateral view. In lateral view, patient position is standing upright with left or right side of thorax adjacent to the image receptor. So in lateral view, it is written as the right or left lateral position depending on the location of the pathology. So as the required side is near to the image receptor. In lateral film, arms are raised above the head, preventing superimposition over the chest, and chin raised out of the image field. So these are the position for the PA, AP, and lateral view. Now some radiation doses in millisievert for the some common X-ray images. So arm X-rays lead to the radiation dose 0.01 millisievert, chest X-ray 0.02 millisievert, dental X-ray 0.05, mammogram 0.60, head CT is 2 millisievert, chest CT 5.8 millisievert, and the single full body CT scan can exposed to the 20 millisievert radiation exposure. And now, thank you.